Hello, and welcome to Bridges at Lakeview Health, our educational series that connects addiction and recovery subjects to our communities across the nation. We want to thank you all for joining us for this special event. Today, we will be presenting a topic on why gender matters and an introduction to a gender-responsive model. For those of you that are unfamiliar with Lakeview Health, we are an adult-only addiction treatment facility located in Jacksonville, Florida. We believe that we are bigger than sobriety and that people can and do change when they are provided with the necessary tools to achieve and maintain sobriety. Since 2001, we've been leading the way in how addiction is perceived and treated and how recovery is managed. We are a passionate team of difference makers whose mission is to empower profound recovery through exceptional, dynamic, and evidence-based care for all individuals and their families. Our commitment to our patients does not end at discharge, but is for a lifetime. Before we introduce our presenters, I wanted to share a few housekeeping items. At the end of the presentation, we will allow participants to have up to 2 minutes to submit any questions they may have. All questions will then be answered. You may enter any questions throughout the duration of the presentation via the Q&A box to the right of your screen. Also on the right of your screen is a chat box for conversations between participants. Throughout this presentation, you are all muted and can communicate with each other via that chat. Please do not ask any questions for the presenter via the chat box, but please put them in the Q&A box. Also, in order to receive full continuing education credits, you must watch the entirety of the presentation, complete the event evaluation, and pass the post-test with at least a 70%. We will be emailing all participants the evaluation and survey information along with the event recording within 24 hours after the event. If you have any questions, please email me at events@lakeviewhealth.com. Presenting today is Sarah Franklin, Senior Program Director at Stepping Stone Center for Recovery, and Philip Warwick, Clinical Manager and Therapist at the STAR at Lakeview Health. Sarah received her bachelor's in psychology from Miami University in Oxford, Ohio, and her master's in clinical mental health counseling from the University of North Florida. She has been a licensed mental health counselor in the state of Florida since 2014. Prior to joining the Lakeview Health team in 2013, she worked for a nonprofit outpatient program, gaining experience with substance abuse and dual diagnosis patients, and also worked in the College Counseling Center at the University of North Florida, where she developed her skills of trauma-informed care. In 2014, she completed levels 1 and 2 of EMDR training, and she went on to pursue her certification in EMDR, which she obtained in 2016. Philip received his undergraduate degree from the University of Central Florida prior to earning his master's degree from the University of South Florida in counselor education with a focus on mental health counseling. He is a licensed mental health counselor and a master's certified addictions professional. Philip has been working as a therapist for Lakeview Health since February 2016. He gained experience in the field while working as a substance abuse counselor at an inpatient facility in Tampa, which focused specifically on treatment for professionals in the medical field. He also served as a field therapist in the Orlando area, working with children struggling with both mental health and substance use disorders. Along with their passion for counseling, Sarah and Philip deliver presentations around the nation that focus on integrating the newest approaches with best practices in the treatment of individuals struggling with substance use disorders. Thank you for your time. Now over to our presenters.
Okay, thank you so much. So, as you all saw in the introduction, my name is Sarah Franklin. This is Bill Warwick, my counterpart. We're going to be presenting together today. It's exciting now that we can get back together and do this sort of semi-live in person. So what we're talking about today is transforming addiction treatment and really providing an introduction to what a gender-responsive model looks like. So at the beginning, we're going to be really defining things like what gender is, why this is even a relevant topic to talk about in the addiction space, and then looking at gender differences in treatment, not just research-based, but also a little bit of anecdotally what we've seen within our treatment center since we went gender responsive. And then we're also going to be looking at practical applications. So looking at things such as curriculum, sort of the content of the treatment program that we have here, and also looking at specifically trauma therapy and how we do that in a gender responsive model. So the first thing that we want to talk about is this paradigm shift in treatment. So back in the 1960s, what we found was that it was non-specific treatment. And really what we mean here is that men and women were treated the same, but all of the research for addiction treatment focused on males and their needs. Now, in the 1970s, the industry really started to begin to recognize gender differences. And this is in terms of biological differences and how psychosocial issues impacted genders differently. Now enter the 1980s and gender-specific treatment emerges. So here facilities are really beginning to start physically separating genders and sometimes even holding gender-specific groups where, the men are in this office and the women are in the office next door. But the content and all of the curricula, all of the therapeutic sessions really were still male-focused. Now, in the 1990s and 2000s, we have what we now call gender responsive treatment. And I think it's really important here that we differentiate between gender specific and gender responsive. So now with gender responsive treatment, not only are the genders physically separated when possible, but the focus is on utilizing a strengths-based approach. And I think that's something that really sets it apart. By understanding the role of things like trauma, by understanding the role of things like relationships and addiction, and really moving away from that sort of like punitive, focusing on character defects type of addiction work.
And if I can kind of jump in just for a second on this slide, because I do like to tell a little bit of a story that goes along with it. And I like to kind of reflect back throughout the history of substance use disorder and the treatment of them. Prior to the 1960s, when basically the only services that really existed to help people with substance use disorders was AA, starting in the mid-1930s into the 40s and 50s. But one of the stories I like to tell that kind of shows you just how taboo, I guess, the topic was is I'll talk with my father a lot. And unfortunately, we have a history of addiction in our family. But I'll talk to my father, and he'll share about his father. And he'll say, well, getting to, with you, what you've been through and seeing your transformation throughout your life, it makes me reflect on my relationship with my father. And he'll say things like, he used to come home and he would be drinking every night, and he would, sometimes drinking until he's blacking out, maybe not every night, but pretty often. But they didn't call it addiction, and they didn't call it a substance use disorder because that was too taboo at the time. It was just, we kept it quiet, we kept it hush hush, and that's how things were. That's how it was for a long time, and that's how people with addiction, before the 1960s, when we started to really emphasize the importance of treatment, had to deal with addiction. It was a thing that they had to keep quiet in the family, struggle with it throughout their lives, and obviously it has huge effects on their lives as a result of that. And so as you see in this slide, how we've gone through generation, 60s, 70s, 80s, 90s, up till today, really making powerful progress in terms of how we treat these disorders, getting rid of a lot of the stigmas attached to them, now to the point where we're even getting gender responsive, where we can really, really focus on some of the underlying issues that are specific to each gender. And so I just like to share, it has been quite a journey, and it's wonderful when we look back at where we were to where we are now, and hopefully, as we continue down that road with progression with the treatment.
Awesome. So anytime we're talking about gender responsive treatment, it's really important to pay attention and give some time and kudos to Dr. Stephanie Covington. So she's been a pioneer in gender responsive treatment. She's focused a lot of her research on women's addiction specifically, the need for quality mental health services. She specifically did a lot of her research with incarcerated individuals in the correctional systems. And she's a clinician who's authored several books. A lot of her work is what we're going to be referencing and talking about today. And she's written about things, not just gender responsive treatment, but also about trauma, about sexuality, about adapting the 12 steps for women. So she really has been influential throughout this entire presentation. And we'll reference this curriculum that you'll see on here in a little bit. So to start off, gender responsive treatment. So fostering a safe environment by focusing on these 4 things. We're going to pay attention to the physical location that we're providing services in. So these would be our facilities, the offices we have, the buildings that we have, the quality and training of staff. So this really addresses how we choose, for instance, at Lakeview, where we have a men's program and a women's program. This goes over how we choose which staff member with their specialty areas gets placed intentionally at each facility. And it doesn't just mean that we take the female staff and place them at the women's program. We really are looking at being intentional about the way we look at specialty areas and how we place staff. Looking at the programming. So every part of the programming has really been intentional. It means looking at things like curriculum. It means looking at things like program schedules throughout the day and how we decide to place and organize the patient's treatment day. And using all of those 4 things to make sure that we have an individualized approach with both men and women and using a strengths-based approach. So making sure that in recovery, one of the things that we're really paying a lot of attention to is building patients up. So using self-esteem, trying to help patients identify strengths in order to help them build a foundation for recovery that they will continue after they leave us here in treatment.
A couple of the areas, the principles, I guess, of gender responsive treatment, and we're going to go through each one of these individually just to give an overview of the next couple slides here. We're going to look at gender and how gender plays a role in obviously gender responsive treatment, but how we implement that into a program effectively. We'll also be looking at the environment, relationships, integrative services. So again, that's that holistic approach to treatment that really encompasses multiple different angles when we start to approach or treat substance use disorders. Economic and social status, and then lastly, we'll look at community engagement and how that can play a role in gender responsive treatment as well. So starting with gender, accepting that gender matters and that ignoring gender-specific issues while in treatment can put patients at a disadvantage. And Sarah already talked a little bit about this a second ago when we were talking about everything at a facility being built kind of from the ground up with gender in mind, everything from the design of the buildings to the programming to the staffing, all with that idea of gender in mind so that when we are treating specific individuals, we can treat them with a plan that's specific to their individual needs as well.
And I think this is a nice place to kind of just like slide in this idea that this process for us and the way we individualize treatment is really pretty fluid. This doesn't mean that we're specifically looking at things like biological sex and making a determination about which patients belong in which program. So a lot of times when we're talking about things like gender responsive treatment, we get questions about where we place patients who identify as being transgender. And so I think it's neat to look at, the way we've evolved our process is to do a lot of assessment on the front end, to really spend time talking with patients, talking with their support network, to find out where patients identify, like along the continuum, where they feel most comfortable, where they feel most safe, to spend some time talking about things like which pronouns do you use? How does your family identify you? How have you been presenting in the outside world? And so we've had a couple different scenarios where we've had someone who's biologically male transition over to the women's program because after coming into treatment, we found out that that was really a program that that person identified more closely with. So really the focus here is that when we're talking about gender, we're talking about gender as a social construct. We're talking about how that patient identifies. The next one is going over environment. So the idea here is that we're trying to build a full environment, not just the rooms, but the buildings and the whole feel of the building, to make sure that patients feel safe, to make sure that patients know that their individuality is going to be something that's respected and really appreciated. So there's two photos on this slide, and I want you to notice the difference between these two pictures. So they're both waiting rooms. The picture on the left is one that they're like entrance rooms essentially. The one on the left is the entrance to the Rose, our women's program. And the idea is that we really wanted to use color and design to foster the sense of safety so that when a patient walked into this program, they know that they're going to be treated as an individual. They know that they're not just another number in a larger system. We really wanted patients to know that they're going to be treated as a unique person. The other thing is that we know that a lot of facilities can have sort of like a hospital setting. So, if you've ever walked into a hospital, everything feels very sterile, feels very clean, often feels really cold. And so we didn't want the entrance, like the very first impression that women were going to have that feel. We wanted it to be warm. We wanted it to be welcoming, to make sure that women walked in and knew that this was going to be different. We know that a lot of women prior to coming into treatment, it would be no surprise to you all, have a lot of trauma issues that they're hoping to be able to address in treatment. And so this first picture on the left is hopefully the first glimpse that will give them the idea that this is a safe place to do something like that.
Yeah, and I'm happy you brought that up, because that's what I was going to touch on too, real briefly. And it's that idea of, if you picture yourself walking into a standard hospital, and you picture the white or gray walls and the chairs in rows. If you've been experienced a trauma, or you have an active addiction or some underlying issues going on, you're not going to feel comfortable in a space like that. But if you walk into an area and it has warm colors, it has comfortable couches, it seems like a place where you can be safe. You're going to feel a lot more comfortable in that area, and a lot more willing to buy into the program, or buy into the idea of treatment and recovery as a whole. Now that picture on the right there is the same idea, but that's on the men's side, and that's the men's library. And so again, we were with the design of a gender responsive facility. The idea is you're creating an environment that is going to be comfortable, so that the people that are in that facility will feel open and willing to get vulnerable and really work on the issues that they're facing.
So the next slide goes over relationships. We want to make sure that the whole facility doesn't have the old top-down approach where maybe the therapists and the doctors sort of have this authority position, where the patients are expected to listen to the staff, talk about things like their character defects. We really want our staff to be modeling what healthy relationships look like, so that they see that the way I would interact with Philip in the hallway might be the same way that I'm going to interact with a patient who I've been working with, right? It has that same level of respect, and showing and modeling some of those same communication skills. And so you'll see two photos here as well. And the photo on the left is from our men's dining area. And you'll notice it has sort of like a sports bar feel, and that was really intentional. We know that patients can use this space while in treatment to start sort of like that desensitization process to what it will be like to go back to an environment such as this, where a lot of men might spend time socializing, spending time together, watching a big football game, so that this environment isn't quite as triggering after leaving treatment. Now, for the women, we know that their set of needs while in treatment are often very different. And so what we know about women is that they often neglect self-care in active addiction. And so we built this spa bathroom to sort of teach women that it's okay to find balance, to teach them that if they care for themselves first, they'll be able to care for others. And we also know that when women come into treatment, they're going to have a higher likelihood of completing that treatment process if they feel connected to peers, if they feel a part of a larger community. So having this larger shared bathroom that the women have allows them the space to get to know one another, sort of removes that barrier that allowed patients to sort of hide in their rooms throughout the day, maybe get ready in their rooms and spend all of the time outside of group in their own rooms. It sort of creates this level of community.
Yeah, I think we might have it on a future slide too, but I'll just mention it right now. That and you said the word community. I mean, that sense of community is one of the main goals of when designing a really effective gender responsive program. We want members of the facility to feel not like they're in a hospital, but they are in a community. And so anything we can do through modeling appropriate behaviors and the design of the complexes, everything goes into that idea of community. There's that common saying in addiction and recovery, and the opposite of addiction is not sobriety. The opposite of addiction is community. And so building a sense of community, building relationships with one another, so that you can foster healthy growth and development is so key.
Agreed.
So we have integrative services. I did touch on this at the beginning, but at a treatment facility, the goal would be that holistic approach. We're really integrating a lot of different services into a patient's length of stay. So in this slide, you can see the various integrative services that are integrated: treating substance abuse, co-occurring mental health issues, and trauma concurrently and in an integrated way. So you have integrative therapy in the middle, and I'll just go around. The outside there at the top, you have the creative kind of expressive opportunities, mindfulness, psychodynamic, family of origin. And actually, we will get into that a little bit more too when we go over some of the stuff in the Stephanie Covington curriculum, because a lot of her material actually covers a lot of the family of origin and family dynamic stuff, which is very interesting. Skill building, and then rational scientific, educating, using the disease model of addiction to educate patients on what's really going on in the brain, so that they're prepared for some of the changes that may occur, or mood swings, or any of the early challenges that we typically see for patients in early recovery. Principles of gender responsive treatment. So we have economic and social status. Pay attention to ways that each gender can improve financial status by addressing occupational issues. So for example, women who report living in households with domestic violence are often deterred from gaining financial independence. So helping patients to develop a plan for gaining income is very important. For a lot of men, self-worth is often tied to the cultural role of being the family's provider. So helping to remove occupational barriers while in treatment can increase confidence and self-esteem. So again, you can see how the main topic of economic and social status is the same, but how we're approaching it in a gender-responsive treatment program is very different depending on the gender.
So the next principle we wanted to talk about was community. And while patients are with us in residential treatment, what we don't want to do is shelter patients completely from the outside world while they're with us. We know that this can set patients up for failure. Treatment naturally has this sort of like sense of being in a bubble and being disconnected, but what we want to do is gradually reintroduce community events and outings. Now, granted, with COVID, we know everything's been a little bit different lately, but the goal is reintegration back into the world. So we don't want patients to become dependent, even on the small community that they form while they're with us. We want them to discharge from our program knowing the resources that they have and feeling connected to some of those things. So, for instance, one way that I think you could see community and this principle really come to life would be the idea of having like outings that we have on the weekend. So, for instance, we've taken patients bowling on like a Saturday. And a lot of patients look at that and tell families that they're going bowling. And I think they only view it as recreation. And oftentimes, until we get the clinician to sit down and explain and sort of process the activity, they don't understand the intentionality. But for us, what we know is that when patients leave treatment and go bowling for the first time, maybe with peers, they might not know what it's like to walk up to the counter to order food or a drink and see someone pouring a beer next to them. They might have never experienced something like this, maybe some type of a sporting activity, sober. And so having the opportunity to have a clinician with them and have peers with them to provide that level of support, I think is so meaningful and so important while in treatment.
Yeah. And I've worked with so many patients who have told me just what you said, that idea of, I haven't been bowling sober in 20 years, and so getting them to a point where they can experience that while in a safe environment with supportive, healthy people around them is invaluable. It's so important, and I think it makes a huge difference. One thing I did want to note on community, and it's slightly off topic, but I think it's worth mentioning just because of with COVID and everything that's going on. We've seen such a huge change in how people are handling recovery as a result of COVID. Pretty early on, we recognized that we were seeing unfortunately, a lot of people relapsing as a result of the isolation that comes with having to obviously stay indoors, work from home, all those changes that were occurring. And so it really kind of beats down that idea of, or emphasizes, I guess, the importance of that idea of community. And we've seen it play out in COVID. When you can't be a part of a community, when you have to do your AA meetings virtually because the in-person AA meetings are closed, or they're not holding those meetings anymore, there is a huge impact on a person's recovery because they're not as immersed in that community any longer. So that community piece, I think, is so incredibly important in the success of somebody throughout early recovery and long-term recovery. Again, the goal is not to stay sober for a year, but we want a lifetime of recovery. And so being immersed in the community early and then sticking with it is so important. And we've had to get very creative with COVID and how we can still emphasize the importance of community in the environment that we're in now.
That's a good point. So this is just a quote that we've included. I think here Dr. Cahill does a really fantastic job of just illustrating the need for paying attention to gender differences. So I'll just read it aloud. He said, "It is dangerous at best and completely wrong at worst to assume that any neurological disorder has the same underlying causes in men and women, and thus to assume that treatments for the disorder will be essentially the same. Yet this is precisely the assumption that continues to pervade much of both the clinically applied and basic science worlds." So again, just illustrating the need to pay attention to gender differences, to know that they matter, to know that if we have a program that's responsive to those needs, the outcomes will be better.
So we're going to dive now into gender differences in treatment, and there's quite a few different areas that we'll look at. Hopefully we'll be able to move through them at a pace so we can get to all of them. But we're going to look at substances used. We'll look at disease progression and how it differs between genders, access and barriers to treatment, the detox process, co-occurring disorders, social support, stigma, and then trauma. We'll finish up with trauma and look at the differences in gender as it relates to trauma as well. Starting with substances used, men are more likely than women to use most drugs. That's just kind of the general idea behind it. For marijuana, the severity of use is higher in males. Disordered use develops more quickly in females. So females that progression of the disease will happen quicker. But the severity of use is higher still in males. For stimulants, things like Adderall, Vyvanse, cocaine, meth, women are twice as likely to seek treatment for methamphetamine and amphetamine abuse. Women are more likely to report using methamphetamine for increased energy. And this is associated with work, home care, child care, and family responsibilities. The mom who kind of works a full-time job, but is still expected to come home, cook, clean, grocery shop, coordinate where the kids are supposed to be and when they're supposed to be there, all those extracurricular things, throwing that all into the mix, trying to cope with all that. We see a lot more women struggling with those methamphetamines for the increase in energy. Yeah,
this one was actually a little bit surprising to me when we started doing the research about these gender-responsive programs. But then what we heard, the same narrative we heard time and time again in the groups that we were running was exactly what Phil's mentioning. I am a full-time mom who also works, who then is expected to come home and do all of the laundry, do all of the cleaning, and then bake these organic gluten-free cookies for my kids' bake sale. And it's just, so many things that are really put on moms, specifically that we see women trying to manage this workload that was just unmanageable. And so stimulant usage was something that they're reporting using.
For opiates or opioids, Oxycontin, morphine, heroin, fentanyl, all those drugs, women are more likely to abuse prescription opioids. Men are more likely to use heroin intravenously. Women report increased likelihood of using heroin over prescription opioids at the request of sexual partner encouragement. So that was a big difference that we saw in the men and women's use, is that oftentimes women were forced/persuaded to use the heroin or fentanyl, some of those drugs, at the request of a sexual partner, which again would be categorized as a form of abuse. And we'll talk a little bit more about that when we get to trauma. But that was a big difference we saw in the research. For alcohol, men have higher rates of alcohol use and increased instances of binge drinking. However, alcohol abuse does result in some unique risk factors for female drinkers. For example, unprotected sex resulting in unexpected pregnancy, transmission of sexually transmitted diseases, increased risk of becoming the victim of violence, and increased risk of sexual assault. And again, we'll touch a little bit more on those when we get to the trauma piece as well.
So if we shift a little bit to talk about disease progression and prevalence, we know that women tend to begin using in lower doses. This could be the result of just cultural norms, what might be socially acceptable for me to do when I go to a bar might be different than what's socially acceptable for you. May also just be the result of tolerance. When you think about physical stature, men in general just tend to be larger than women. But we also know that substance use progresses more rapidly into dependence with women. So if you think about that, if Philip and I started using the same substances, what we know is that I'm going to move more quickly into dependence than Philip would. Okay, and so these results have also been replicated with lab animals. Whether or not you feel good about that, I don't. But the fact of the matter is that they've shown these gender differences with different types of animals as well, that the rats actually in this study, the female rats became physically dependent on the substance more quickly than the males did. So that's interesting.
Well, another interesting thing about that progression outside of the animal abuse potentially, but outside that, with the disease progression happening quicker, there's advantages and disadvantages to that, because when you look at it, if a disease of addiction progresses quickly, it oftentimes means that you will seek help earlier. Whereas if the disease takes a lot longer to progress, while it may not be as severe, you may not have the as severe as consequences, you typically will have more consequences, just less severe as a result of that progression. So it is interesting when you look at the progression of the disease and how it affects men and women differently when you look at the consequences.
Absolutely. Now, moving on a little bit to access to treatment. So anecdotally, when we looked at our admissions here at Lakeview, we found that about a third of the admissions overall were women and about 2/3 were men. What we found, and research supports this as well, is that women were more likely to be internally motivated for treatment. And so when we're talking about internal motivation, I'm talking about, waking up one morning and really wanting change for myself, wanting change for my family, making that decision and really sticking to that for me. When we think about men, we saw a lot of what we would call external motivation. So maybe this is a man who gets sit down by his supervisor at work and says, Philip, I've noticed your performance at work is changing. I really want you to seek treatment before coming back. Okay, so now he's motivated to come to treatment, but it's often because of wanting to maintain that job. Or maybe it's because of legal consequences. So maybe a probation officer says you need to go to treatment or, risk suffering these consequences.
Ultimatums from family members.
Exactly.
Is another one. One thing that I do want to note on this slide is, there was a thought for a while, and I used to hear it all the time, about how if somebody's not internally motivated, then they won't be successful in recovery. I used to hear that a lot. And what I found in working in addictions for as long as I have is that we get a lot of patients who come in, men specifically, who come in externally motivated. Through the course of treatment, will find that internal motivation. They'll start to discover the advantages of sobriety, the advantages of recovery, and then they'll buy into it a lot more. So even if a patient comes to us externally motivated, we will still, work hard on getting them to a point where they're comfortable and they get that internal motivation, so that they can be successful in recovery and hopefully change. If they came here for work, maybe they leave here for themselves. That's probably one of the best things about working in addiction, is being able to see that.
I think that's a really important myth to dispel, because all the time I'll hear from family members saying, so-and-so isn't ready yet. They're telling me they don't want it. And so I feel guilty, creating this barrier for myself or our family, because if I send my husband to treatment and he doesn't want treatment, is he really going to change? Is he really going to get better? And like Philip said, time and time again, we see it happen. Talking about barriers to treatment, do you want to maybe talk about the men and I'll talk about the women?
Sure, yeah. So when we look at the men as it relates to barriers to treatment, we hear a lot of, and this may kind of go back to that last slide a little bit with external versus internal motivations, but people can come up with a million reasons to not seek help when every day is just getting worse and worse. And so some of the common things that we hear is not feeling like they have a problem is a pretty common. It's the straight up denial of the addiction, or at least not thinking that their problem is significant enough to seek treatment. Perception can overcome addiction on the perception that they can overcome addiction on their own. And we'll see people who spend 1, 2, 3, 5, 10 years trying to overcome addiction on their own until they finally just say, okay, I'm going to surrender and buy into this process of recovery. Belief that treatment, or buy into this process of asking for help, better yet. Belief that treatment is a sign of weakness. I think that the gender responsive treatment programs have done a great job of getting patients to understand that treatment is not a weakness, it's a strength. Having the courage to reach out and ask for help, and having the courage to go to an inpatient facility and complete an entire length of stay, I mean, that takes a lot of courage, and in no way, shape, or form is a weakness. So, but again, these are some of the things that they have in their heads prior to coming into treatment. Feel they are a functioning addict. We get that a lot. I show up to work on time. I get good reviews. But when you look at the whole picture, and you look at the family, and you look at hobbies, and you look at all these other aspects of life, how is everything being affected by your addiction? And if you get honest with yourself and you look at all these different areas, then you can typically overcome that barrier when you look at all the different ways addiction is affecting you. The financial obligation to family is a big barrier that we see. Oftentimes, men will resist coming to treatment because they don't want to put their family in a financial bind. The reality is, the longer that they stay in active addiction, typically, the more financial stress is going to result. So the quicker they can get into treatment, even if it means taking a financial hit in the moment, they'll be able to recover as a result of being in sobriety and being able to put that much more time and effort into their work and financial responsibilities.
An investment.
There you go. Yeah, that's the best way to look at it. It's an investment. And then the fear of damage to their career. And again, that can be a big barrier. But the flip side of that one is if you don't seek help, the disease is progressive. And so it will continue to affect you in bigger and bigger ways until you either lose your job or worse. So barriers can cause men to seek treatment later in their disease as a result of all these barriers. And it contributes again to that progression of addiction.
Mm-hmm. Now, for the women, a lot of times we see women, both before and after treatment, having more financial insecurity than men do. Although I think gender differences and norms are changing throughout culture, we still see men being the breadwinner more often than not. We also know that women tend to be the primary child care providers. And so even in a home where it's 60-40 or 70-30, we see women have this sense of guilt about leaving the family and taking time that they often call selfish to come to treatment and focus on getting better for themselves. It's a difficult decision to make. And so we know that lack of childcare is often a barrier for women. Even if husband is staying home, even if husband gives permission and says, go to treatment, I'll take care of the kids, it's a lot of times a sense of guilt, but sometimes it truly is a lack of adequate childcare. We have a lot of women who we treat who don't have the assistance, who don't have someone else at home, a partner to help take care of the children. Inability to complete treatment due to family responsibilities. So this would be, women not being able to stay for a full length of stay, women not being able to commit to something like a full residential program because of their role at home, because of needing to get back to that. But I think this last one's important to pay attention to. So when you think about co-occurring mental health issues, we know that the majority of our patients who come into treatment have both a substance use disorder and also co-occurring mental health issues, things such as anxiety, depression, bipolar disorder. But we know that women have an increased likelihood that they suffer from co-occurring disorders. And a lot of times this even prevents women from coming into treatment. So imagine someone who has anxiety that's become so crippling that the thought of leaving all of their responsibilities, leaving everything at home to go off to this new place where they don't know anyone, where they don't know what the process looks like, to enter in something like sobriety, which can be pretty fear-inducing as it is, we see that the co-occurring issues often become barriers for patients coming into treatment.
Even to add to that a little bit as well, I think oftentimes with that co-occurring issue, and I've seen this quite a few times on both the men and women's side for that matter, but a patient will have the stance of, I'm not an addict, I have depression. And so if I can treat the depression, then the addiction is just going to go away. And so that can be a barrier to them coming to a treatment facility for addiction when they feel like their real problem is the depression, even though we know that the addiction is going to be something that they're going to need intervention for.
Good point. When we look at detox, I thought these facts were really interesting, so I think it's important to share these things too. We know that women tend to be physiologically sicker, so they feel worse, like they feel physically ill from detox in a different way than men do. So what research has shown us is that women have a more difficult time getting like a head start or a jump start in treatment. Oftentimes we see patients who are in detox in our women's center, struggling to make it to group therapy sessions because they're feeling so sick. I think there's a lot of jokes about the differences between men and women when they're feeling ill. Like if we both have a cold, I think men get, teased a little bit for having, symptoms. But what we know is that women really feel the physiological symptoms of detox worse than men do. And so this was another reason that we knew we needed to spend a lot of time and effort connecting women with peers in the community so that they're going to be connected, have that source of support to get them through that hard time. We also know that women are more susceptible to things like craving, which obviously is related to relapse and relapse potential. But men tend to metabolize chemicals more quickly than women's bodies do. So we know that a lot of times it takes a different period of time for like Phil and I to metabolize the same substance. And I think that's important to pay attention to. And it's important to have clinicians and doctors and an entire staff that understands that difference with men and women, especially in the detox process.
Yeah, for sure. So we'll look a little bit deeper into the co-occurring component, and I know Sarah talked about it a little bit when it comes to mostly to the women's side, but we'll look at the men's as well. So men do present with fewer co-occurring mental health diagnoses than women, but they do have the higher rates of ADHD and depression. Now, I will say this, while men do present with slightly lower rates, it's still pretty prevalent. The majority, or I would say the majority of patients that are coming into a treatment facility, or at least Lakeview, are going to have some sort of underlying co-occurring disorder. And again, the difference being what underlying disorder it is. And in the men, we see typically a lot more ADHD, depression. On the women's side, we'll see a lot more of those anxiety and mood disorders, trauma, although I would argue that we see trauma a very large amount on the men's side as well. The kind of trauma is what really differs with that one. And then lastly, on the women's side, eating disorders. Although, again, with that one, I would argue too that we are starting to see more of the eating disorders on the men's side as well.
And I think that's one of those where it's been more socially acceptable for women to report something like an eating disorder than it has been for men.
And I think too, along with that, that's that gender responsive treatment and the men feeling more comfortable is allowing us to kind of uncover a lot more of those underlying issues, including like the eating disorder.
Absolutely. When we look at social support, we know that women are less likely to have support of their family or their close social circle. We touched on this a little bit ago, but women are often viewed as selfish for wanting to leave their families to focus on themselves and really use that time for self-care. Whereas a lot of times we see men as being sort of applauded and being called brave to take that step and to leave the family to go off to treatment. So shifting gears just a little bit, we wanted to spend some time talking about trauma and how trauma is impacted by a gender responsive model. So first, to go over a few differences that we've noticed. We know that as children, both boys and girls suffer pretty similar rates of abuse, but as Phil mentioned, the types that they're reporting are different. So girls are reporting higher rates of sexual abuse, whereas boys are reporting higher rates of things like emotional abuse and emotional neglect and physical abuse. So as children progress into adolescence, we see that boys are at greater risk if they're gay, young men of color, or involved in gangs. We also know that young men typically tend to be abused by people who dislike them, people who identify as hating them, whereas women, interestingly enough, tend to be abused by the people who are telling them, I love you. So I think that's pretty striking. So imagine romantic partners, think family members. Those are the people within that close social circle who tend to be the abusers. And I think obviously that has ramifications for when patients are coming into treatment, because what we know is that it's not that women socialize and talk with one another less than the men do, but we see the women's interactions with one another being more superficial. And I think we addressed this on a later slide too, but it's important to notice that the women take a longer period of time to trust one another oftentimes, and because of these traumas.
Yeah.
We know that as adults, men and women tend to experience different types of trauma as well. So men are reporting more physical violence, men are reporting more grief and loss. And oftentimes I think when you start to peel back the layers, this is really the safest form of trauma that men feel they can report, especially upon coming to treatment. A lot of times we'll get male patients who come in and during that initial assessment will say, well, I've lost people, but everybody loses people. My therapist told me I should seek trauma therapy, but I'm not sure why. And so that's usually like the safest starting point to start delving into some of the trauma.
Yeah.
The women report high rates of emotional abuse, especially as adults. And this is really, I think, interesting as well. So what we know is that women retain emotional memories in a more vivid form. And so when you look at trauma therapy, especially in an addiction setting, imagining that it's different for both the men and women to be discussing things like this in groups or individual settings, to know that what's happening internally when I recount an event might be different than what happens internally to a male when he recounts an event, is certainly something that I think you'll see when it comes to gender differences playing out in these groups. So these are some of the things that we assess for when we're completing what we call a trauma group orientation, and we're trying to determine whether or not this individual is ready to start something like trauma therapy. So we approach this from a really individualized, holistic approach, I would say. And so the first thing we're going to look at is whether or not this person has some type of safe coping skills. If we're removing the drugs and alcohol and telling somebody that this coping skill they've been using that maybe has been working to some degree is no longer going to be something that they have, we need to make sure they have something, some skill. And it can be something that we teach while they're here in treatment, like mindfulness, like meditation, but they need some type of safe coping skill. We want to ideally make sure that there's no major current crisis or instability. So for instance, if we know that Johnny just entered treatment yesterday and tomorrow he's getting served with divorce papers, trauma therapy is not going to be the highest priority at that time. We'd like to have some sense of stability if possible. Number 3 is always an interesting one. So we want to make sure that the patient is willing to work on the trauma. And that seems really obvious. And you would think that if they're showing up and they're saying that they want to work on the trauma, certainly they're willing. What we find more often than not, though, is that for the women especially, they may come into treatment and say, trauma is my primary issue. It's the reason I'm here. It's what I want to focus on. But every day that trauma group comes around at 3 p.m., there's a scheduling conflict, or the woman has a headache every day at that time, or there's these like subtle ways to try to avoid that work. And so in that scenario, we're getting mixed messages, right? The person's saying that they're willing to do the work, but really showing us the opposite. Needs to demonstrate the ability to ask for help when needed. And again, this is something that we can certainly teach and provide resources for. Ideally, somebody who's not actively using substances, and for our patients here in treatment, obviously that's something that we have the luxury of having. Not actively reporting suicidal ideation. I think there are times, and we always have to address this individually, that until we're able to provide some resource building and some coping, we're never going to remove that passive suicidal ideation until we can address some of that trauma. So these aren't hard and fast rules. Again, you need to sort of use these as a guide and individually tailor them to each patient. But we'd also like to have some consistency in the coming weeks. So if we know someone's going to be discharging from treatment next week, that's not our ideal time to start trauma work, because we want that person to have the safety and the security of the group, of the peers in treatment, of the staff, to be able to start some of this deeper level processing.
You know, we along with number 7 too, and you kind of hit it right there at the end. But even if they aren't discharging in the next month or so, we want to make sure that we have a plan in place so that when they do discharge, the aftercare is going to include continuing to address that trauma, which would be equally important. Yeah.
So we're going to move on to how to apply gender responsive treatment within your center. And I want to be mindful of time, so we may need to go a little bit quickly through these, but we're going to be talking about briefly the benefits of gender responsive treatment now that we've sort of exposed you to what they are. Talk about some of our anecdotal observations from being in the women's and men's centers here at Lakeview, and then do a quick introduction to some of our gender responsive curriculums.
So we'll start with the benefits of gender responsive treatment. And again, like Sarah said, I'm going to move a little bit quicker through these. So we do have some time at the end for some questions. But in terms of benefits, building healthy relationships with peers of the same gender, we've already talked a lot about that importance of community, so I won't touch too much more on that. Reduction in romantic relationships in treatment. I can't stress the importance of that. I worked at Lakeview prior to us going gender responsive, and then I was a part of us as we went gender responsive. And just that splitting of the genders in the very, very beginning, the first thing we saw was obviously that reduction in romantic relationships, which was, I think, a blessing for everybody.
And it's not to say that we don't have same-sex
couples. Yeah, that's very true. Yeah.
But reduction is
absolutely. People can confuse that emptiness and that predation as romantic love and build their stability on that. And we all know how stable relationships are in early recovery. They dissipate quickly, and they need the relationship with other women to support them through that. That's a quote that kind of sums up that idea of the dangers of relationships and the importance of building healthy relationships with same sex. Discussing trauma and self-esteem issues more openly in gender-specific groups, it allows patients to really drop down those barriers, get a lot more vulnerable, and share a lot more quicker too. We see that happening earlier in treatment and to a deeper level. And then lastly, a focus on gender-specific needs that are, again, individualized.
So this next slide is probably my favorite within the whole presentation. It's because I think it looks at not only what we know within the research, but also then what we've seen within our treatment center. And so we'll kind of talk about both sides, but to focus on the women and what we've observed, we already referenced the fact that they often take longer to build a genuine relationship with other women. So we'll see the superficial connection in the beginning, but to form that closer bond, it takes more time.
And then on the flip side, men tend to build those connections pretty quick, which is wonderful to see. But we also see that reduction in using humor as sort of a mask to deflect it. Now, we do still see it, but it gets greatly reduced when you go gender responsive, which is awesome. Especially
in the way that when we were co-ed, the men would sort of use some of that humor as like posturing, almost in a way to sort of maybe impress some of their female companions. So we've certainly seen that change. With women, I cannot tell you how many times I've heard this statement here. Most of my friends are guys. I feel uncomfortable around women. And a lot of this is the result of a lot of the trauma that women have endured, especially think about like those adolescent ages where a lot of times women are not typically very nice to each other. So our job is to start fostering that sense of safety within female relationships.
Yeah. And then on the men's side, we see that increased display of vulnerability, expression of different emotions, which I've already talked about that quite a bit, but that increase in vulnerability is wonderful.
So after women build that trust, they form this sort of like sisterhood bond, which is really incredible.
And then strong camaraderie on the men's side.
We know that women participate more actively in groups without males present. So when we had co-ed groups, we saw women sort of playing this caretaker role, where if the two of us are in group together, I might identify with Phil as being somebody similar to my son or somebody I want to care for. And so I would maybe sit back and let him have the floor, right? Women taking on that caretaking role. But when you remove then from the group, women start participating more actively, advocating for themselves more actively.
And then in the absence of women, men will take on the caretaker roles and support each other. When you get rid of the distraction, it allows them to really focus on one another and how they can help one another. And it's really wonderful and beautiful to see some of the guys go up to some of the men who are struggling and show them the ropes and kind of help show them around and give them a helping hand. And that's recovery too. I mean, that's a lot of 12-step work right there. And so it's wonderful to be able to see that in the community.
With women, we saw less focus on personal appearance. So no longer did we see as often women being late to groups because of things like doing their hair, doing their makeup, getting all dressed up for group. A lot of women now wear athletic clothes to group, wear things that are comfortable.
Decreased sense of competition on the men's side.
And then across the board, we see that men and women both stay in treatment and stay engaged in the treatment process longer when it's gender specific.
Absolutely. Yeah. So these are the gender responsive curriculums that we use at the facility. You can see how you have a woman's journey, helping women recover. And then on the right side there, we have a man's workbook, helping men recover. I'm going to have you actually click forward. We're going to go through these pretty quick because we're running out of time here. So some of the key issues addressed, there are 4 modules in each of the books. And the 4 modules are self, relationship, sexuality, and then lastly, spirituality. And we'll click through these real quick, and you can see how a lot of the topics are similar, but when you look at the actual structure of the chapters, they're very different in how they approach each one of these sessions. And so it is very interesting to be able to run the groups on both sides and to see how different they actually are when you're treating a lot of these issues. There's sexual attitudes and behavior scale as part of the sexuality module. I do have an example of the men's sexual attitudes and behavior scale on the next slide here. Again, I'm not going to spend a whole lot of time on it, but you can see how this scale talks about things like masturbation and sexual arousal and things like that. And if you put yourself in a room, you can ask yourself, would I be comfortable if this was mixed gender, or would I be more comfortable if this was in a gender-specific group? And when you start to look at it that way and you see some examples like this, you can see how gender responsive treatment can make a big difference in how vulnerable you're going to be willing to get in a group setting. And then the last module there is spirituality. We really dive into what spirituality means to you, whatever it means to you, and how you can incorporate that into a healthy recovery.
So just to sort of summarize all of this, we wanted to talk about how to integrate this into your own practice. So intentionality is certainly key. Intentionality in everything that you're doing. And knowing that you don't have to have a gender separate campus the way we do to be able to use some of these principles of gender responsive treatment. I think that's really important. A lot of people say to us, we don't have the luxury of having split campuses. And so I think it's important to know that as long as you're using a strengths-based approach, as long as you're working to individually tailor treatment to the unique needs of men and women, and as long as you're paying attention to gender, so just having a lens that's mindful of gender and how it could impact issues, you too could use this in your practice. Okay, so we cut it close. So we want to make sure that we have time for any questions if there are. Okay, so it looks like one question we had is how do you support those who do not identify male or female, but more non-binary or gender non-conforming? So we did touch on this a little bit. It's always individualized. A lot of people say, but if they're not on hormone replacement therapy, would you still accept this biological male in the women's center? And to that, we would say yes. There are no, hard lines in the sand that tell us where we would specifically put somebody who's male or female. It really is about a heavy assessment on the front end, and sometimes not even until the patient gets here. Sometimes patients don't even disclose some of these gender issues until they're in treatment with us. But being responsive and being respectful, making sure that we're meeting those needs. So oftentimes we'll offer patients who are somewhere on the continuum of identifying as something other than strictly male or female. We'll offer them their own room. We'll offer them a lot of different options. And then weeks into the program, they're saying, I feel very comfortable in this program. I want to engage in things like trauma group. I want to share a room with peers. So we've been very fortunate, I think, so far. And I think that's been the result of us not having any hard and fast rules and just being responsive to what people need.
Our goal is long-term recovery for these patients. So whatever advantage we can give them in accomplishing that goal, we're going to work with them to make sure that they're comfortable at our facility.
Absolutely. And then there's a question about receiving a copy of this PowerPoint. And I believe that can be made available as well. Looks like that was answered. If there are any other questions, feel free to add those now. Otherwise, we can also provide our contact information in case there's any follow-up questions or anyone had anything that they wanted to share with us. Absolutely. We're certainly available and want to help out. We appreciate your time today. Thank you for joining us.